Hello, and thank you for the opportunity to present the results of our study investigating pelvic floor muscle activity in patients with quiescent inflammatory bowel disease using transperineal ultrasound. This was conducted with the assistance of my co-authors at St Vincent's Hospital, Melbourne, Australia. I have no disclosures. Pelvic floor muscle dysfunction has been identified in patients with inflammatory bowel disease and is thought to develop over time in response to adverse stimuli, which frequently accompany inflammatory bowel disease. These include pain, loose stools, urgency or anxiety, and may lead to poor muscle contraction and relaxation, which can then impair continence and defecation. Pelvic floor muscle dyssynergia has been reported in over 40% of patients with IBD in remission and impaired defecation, and can be responsive to biofeedback training. Non-invasive methods of assessing pelvic floor muscle action are desirable for patients with IBD, especially when rectal examination is painful or distressing. Transperineal ultrasound is a useful biofeedback tool with minimal setup time and provides a view of the anorectal angle moving during pelvic floor muscle contraction and simulated defecation. It has been shown to correlate well with digital, manometric and defecating proctography assessments. The aim of our study was to assess pelvic floor muscle action using transperineal ultrasound in patients with IBD in remission and persistent bowel symptoms, and to determine whether these measures are associated with symptoms or treatment outcome. Ultrasound assessments were performed as part of a physiotherapist-led behavioural intervention study for patients in IBD remission with fecal urgency, fecal incontinence or impaired evacuation. An assessor blinded to symptoms performed the examinations with the patient reclined, hips and knees flexed and back supported. Patients emptied their bladder and the transducer was placed on the perineum in the sagittal plane. A brief practice of pelvic floor muscle contraction preceded the recordings of 3 maximum pelvic floor contractions and 3 simulated defecation efforts. The best images at rest, maximum contraction and maximum push from the cine loops were analysed by a second examiner blinded to patient data. The anorectal angle and the maximum displacement of the anorectal angle were measured. The methods for image extraction and measurement were tested for reliability prior to analysis. These images are oriented with anterior to the right and superior to the top of the screen. The anorectal angle was measured by placing a vertical line on the anteriormost point of the anorectal junction, the inflection point, and tangents were drawn from this point along the posterior anal and rectal walls. The distance between the inflection point and the most posterior point of the pubic symphysis was measured by establishing the scale of pixels per centimetre for each image. This distance was taken to represent puborectalis length. The direct displacement of the inflection point on contraction and simulated defecation were also measured, shown here on the left in yellow. The image on the right shows the direct displacement vectors in each anatomical plane, anterior, posterior, inferior and superior directions. A pixel per centimetre scale was used to measure displacement on the X and Y coordinate system shown in the bottom left corner. 33 patients were assessed at baseline, mostly female. The inflection point to pubic symphysis distance or puborectalis length was measured in 21 patients with a clearly identifiable pubic symphysis. The measured distances at rest, on maximum contraction and with simulated defecation are listed with the mean changes and percentage change, which were 11.5% for maximum contraction and 11% for simulated defecation. The percentage changes in length which have been reported for healthy female controls are almost double these, at 21 and 19% respectively. Continent patients were able to reduce the puborectalis length with pelvic floor muscle contraction significantly more than patients with fecal incontinence. 22 patients had ultrasound assessments for comparison before and after treatment. All patients produced an anterior displacement of the inflection point at both time points, which increased following training. There was a wide range of displacements from 0.8 to 22.8 millimetres. The direct displacement of the inflection point with maximum contraction also improved following treatment. Although these were not statistically significant, the effect sizes were moderate. 50% of the patients failed to achieve a normal posterior-inferior movement of the inflection point with simulated defecation at baseline. Following treatment, 73% were able to demonstrate this correctly. Inferior and direct displacements with simulated defecation reduced after treatment, suggesting there was less downward straining force applied. The anorectal angles were more difficult to measure accurately, and none of the angular measurements changed significantly following treatment. There were no significant correlations between any of the ultrasound measures and patient-reported improvement or symptom severity following treatment. We found strong correlations between the change in puborectalis length and both the direct displacement and anterior displacement on maximum contraction, making these suitable surrogate measures when the pubic symphysis isn't clearly visible. This was a small cohort, and the results are not generalisable. The ultrasound measures were not compared to other methods of assessing pelvic floor muscle activity, such as EMG or digital grading, so other factors could account for the movements observed with ultrasound. Simulation defecation was not practiced in a physiological position, and patients may have been concerned about incontinence. Patients with fecal incontinence were not able to reduce puborectalis length as well as continent patients at baseline. All patients were able to produce an anterosuperior movement of the anorectal junction with pelvic floor muscle contraction, but half failed to produce a posterior-inferior movement with simulated defecation. The percentage change in puborectalis length was reduced compared with healthy controls. Displacements of the anorectal junction are easier to measure than the anorectal angle. They improved following treatment and correlated with measures using the pubic symphysis. Ultrasound measures were not associated with treatment outcome. Preliminary findings suggest that pelvic floor muscle function is compromised in some patients with IBD in remission. Anterior displacement of the anorectal junction with pelvic floor contraction was simple to measure and correlated strongly with the anorectal junction to pubic symphysis measurement. Ultrasound was well tolerated by patients with IBD and was a useful adjunct for this patient group. Powered studies are recommended to further examine the relationships between ultrasound measures and clinical outcome in symptomatic patients with quiescent IBD. Thank you for your attention, and I'd also like to thank my co-authors for their assistance with this study.